Hello, I'm Kathleen Warshawski, President of the Dallas Area Gerontological Society. On behalf of the Forum Committee, I'd like to welcome you to the 2020 Annual Fall Forum, the year everything changed. And now I'd like to take a moment to introduce you to our first speaker, Dr. Jacqueline Naeem. She is going to talk to us about social determinants of health. And while I am pulling up while I am reading her bio, I will have her pull up her presentation. Dr. Naeem, are you able to do everything now? Are you able to screen share?
Yep, I'm just pulling it up now. Thank you and good morning.
Good morning. So Dr. Jacqueline Naeem is currently serving as the Parkland Center of Clinical Innovation Senior Medical Director and AHC Program Director. She is an experienced physician with a diverse professional background, utilizing experience in both general practice and psychiatry to lead a range of successful projects. In her role as director for a Centers for Medicare and Medicaid Services grant, she uses her clinical expertise to lead a program that identifies social needs and connects individuals with resources to improve health and reduce ED utilization. Other projects and focus areas include correctional health and reentry, suicide screening and prevention, and using social determinants of health to drive health interventions, including the development of a predictive model to identify which patients were likely to require post-acute care upon their discharge from a large safety net hospital in Dallas. Dr. Naeem also oversees the program evaluation for several large philanthropic community-based grants. It is my pleasure to welcome Dr. Naeem to the DAGS Fall Forum.
Thank you so much. I am just pulling up my presentation here, so bear with me 1 second. This here. All right. So good morning, and thank you so much for allowing me to come join. I've not attended this event before. My colleague has attended in the previous years, and she was really excited to hear that it was being able to be done virtually, and was excited for me to be able to share with you, as she's really enjoyed it in previous years. So what I wanted to kind of focus on today when we talk about social determinants of health and how we use data when we're addressing those needs, and how we can link the healthcare services and also the community services, as they're all looking after the same individuals, in order to look after them a better way. I've also included some information about how we've kind of adjusted and reacted to the pandemic, and the way that we've continued to use data to drive our decision making and also to improve care for individuals. Okay, so just to kind of level set, when we're talking about being healthy, you know, we talk about not only physical health, but mental and emotional health as well. So when we're caring for a person, thinking about the very holistic approach and thinking of addressing all those needs and the things that drive those areas of health. So social determinants of health is all the things that contribute to somebody's health. Those are the things that are happening outside of the hospital or the clinical environment. You know, they include biological, social factors, where people live, you know, what kind of jobs they have or had, and the activities that they pursue. So I work as a senior medical director at PCCI, and just to give you a little bit of introduction to what we do is we use data to develop programs and models, predictive models, to address healthcare problems and needs and trying to develop solutions. We consider social determinants of health in all of the projects and programs that we engage in, and we try to work together to align the services to come together to provide the optimal care for an individual. Because when you consider that it's the same person, as I mentioned, that's in the community as that we're seeing, in the hospitals, in the clinics, in other environments as well. So it makes sense to bring data from all those sources to try and understand how we can best serve needs. So right now, we're kind of playing a reactive role, and I say we as kind of the healthcare profession in general, is that we are trying to care for needs that arise when people are ill or sick or not coping or not managing very well. But the problem with that is that if we were just able to get a little bit ahead of those things and think about the things that are happening at home, in the environment before people become ill or unwell, then there's an opportunity to intervene and perhaps not necessarily stop people from becoming unwell, but at least allow them to maintain their health to the optimum level for that person. All right, so when we think about seeing people in the healthcare system or in the hospital system, sometimes it almost becomes like a separate person, where the patient you're caring for, you're seeing them in the clinical environment and you're addressing those needs as they should be, because those are probably the acute needs or the things that you need to deal with at that present. But oftentimes there's a disconnect between thinking about what's going to happen to them once they go back to their community, back to the place where they live and are managing themselves most of the time. So right now, what we're doing is trying to make referrals to the community to help those needs be met, but oftentimes we make referrals and we never know what happens to the person afterwards. All right, so when we think about the person and the things that can be troublesome or problematic or barriers to kind of optimizing the health, is we need to make sure that we understand that we're asking the right questions. We need to really understand that we know what things are like for an individual when they are at home and they're not with us in a clinical setting. So do they have family around? Do they have support around? Do they have people that they could call? Particularly, you think about during lockdown and during the pandemic, we saw lots of people that were really struggling because they weren't interacting with their family members because they were following, they were doing the right thing, but they weren't interacting with their family members. They weren't seeing the, having their congregate meals or going to their church events or their local events where they have that sense of well-being and the sense of community and support. The other thing that we think about when we're seeing someone is making sure that the person, we're considering kind of what they would like to happen as well. So not only kind of dictating this will happen and you'll be referred here and so on and so forth, but understanding what is important to the individual and addressing those things and working together. And not prescriptive kind of instruction, but more collaborative instruction, including with the individual, if they would like their family involved, their family, and so on and so forth. And then trying to make a plan to keep things a little bit more stable and have things set up so that when people are sent home from the hospital, for instance, that it will be a successful transition back to their home or their community or wherever they're living. And we're not setting people up to fail, that we're setting them up to succeed and be well supported wherever they are going. So when we think about sending people back to the community and the resources that they're there to help support them, then the issue of access comes up. Now we think about access in terms of services, we need to make sure that those things are in a reasonable location for the person if they're expected to travel there, that they're eligible for the services that we would like them to receive or think they need, and also whether those things are available. So these can also often cause barriers or difficulty where the presumption is that these referrals have been made, that the person will access these things, yet because of some things as listed, they will not be able to get those needs met. Okay, so when we think about whether we're all working together from the clinical community and keeping the individual and the person in the middle of all the things that we do and at the center and forefront of the action plans, we need to understand that the clinical side is often thinking about things like, you know, what's the diagnosis? What medications do they need? What are we going to do next? You know, when do they need their next blood test? So on and so forth. And the community services don't have that insight often to those sorts of things. And they're thinking more about, you know, how can we get this person, if they need food, if they need transportation to those hospital visits, so on and so forth. So trying to make sure that everybody is sharing the knowledge together. In addition to understanding that the person in the middle, we need to be focused on them and understand what they have available as well, as I mentioned, in terms of social support and family, friends, be it virtual right now or whatever way they're able to have that ability to support, or if they're missing that support. So as mentioned before, when we're thinking about, the services that we're trying to get people to do, we want to make sure that all these aspects are addressed, that they're eligible, that things are available, and they're at a reasonable location. So one of the programs that was mentioned during the introduction that we do at PCCI that I look after is one of the CMS models looking at the accountable health communities. And the aim of that program is to see whether by addressing those social determinants of health, by addressing those needs, we're able to impact healthcare costs and healthcare utilization. So through the program that we do, we identify patients that are eligible, but that's by having Medicare, and we use community navigators to connect them to the resources in the community. There's a screening questionnaire that goes through the core needs as identified, which are housing, food, transportation, safety, and utilities. So there's questions about all of those, and there's resources available for each of those needs. So this is kind of the workflow here. So someone's encountered at a clinical site, they're screened, they are entered into our IRIS, which is now called PIECES, and that is the information exchange platform that serves as a case management tool, but it's also a closed loop referral system. So that means when we identify these individuals, we are able to make the referrals to the community-based organizations through the software system. We're able to see whether they attend those appointments or the referrals, or whether they connect with those services, and then we can get feedback regarding whether those needs were met or not met. And this is really beneficial in terms of planning which particular community-based organizations we might need to engage a bit more, which needs are coming up more frequently that might perhaps be more difficult to address, and also how engaged people are. So when we're making referrals, are people actually showing up? Because that's always the question, isn't it? Whether you're sending someone somewhere and you never know if they get there or not. So it's a really beneficial system to be able to see from both sides. And it does allow a nice linkage between the clinical environment as well as the community. So this is kind of what we're aiming to do, and what we're trying to do is get the bi-directional healthcare information and also social information between the community and the clinical environment. There are still some challenges, and there are things that we can improve on this. For instance, sometimes there are not. So right now, as I mentioned, the program that we're doing it's a funded program by CMS, and we can't offer it to everybody, even though it would be fantastic if we were able to do so. So there's not the resources available to expand the program as it is at present. If that was able to do so, we've talked before about the impact it could have, particularly on the uninsured patients who might have several or these needs and need connecting with the services even more, which would be a benefit to them and probably improve their overall health as well. So the other thing that we struggle with at times is that there's a little bit of a mismatch with the funding for the community-based organizations and the health kind of issues or needs that we're finding within the people that are using the services. And then, of course, as you can imagine, with any data sharing. The platform I mentioned that we use at PCCI, it's HIPAA secure, but there's still an element of, community-based organizations in particular, they might not be wanting to kind of be involved in such a robust data system, perhaps. They might not have the staff trained to be able to utilize the technology platform. Lots of the places we engage with use volunteers. And as you can imagine, there's frequency and turnover. There's people that, because the systems or the sites, organizations, community organizations are often very, very busy and overwhelmed, that it's an effort for them to get on this platform and to kind of track this data and to submit the data and so on and so forth. And then, of course, you come across the need to have, robust legal agreements in place to ensure that we're, being respectful and protecting people's information and data. So the other thing that we've talked about is that what we need to do is to be able to kind of aggregate that data. We want to be able to take the data from lots of different sources and to be able to bring that together in one place and then allow that to drive our decision-making process and allow shared information and collaboration across the community, hospital system, and overall impact the care of the patient. So this is just a very brief example. This is just a made-up person, but it's kind of a persona based on lots of the individuals we've encountered. But you can imagine that when we start talking to a patient, we start understanding what things are like for them. So for instance, if someone came to the clinic, this gentleman perhaps would come in for his diabetes. And rather than just kind of checking his HbA1c and adjusting his medication and sending him on his way, we dive in to find a little bit more about what his life is like, what things are like for him. So as you can see from like some of these things, we can understand where he lives, who he lives with, the needs that he has, and also some of the challenges that he might be facing. So we can understand by using the data that we collect from IRIS or PCCI, we're able to kind of pull this sort of thing together and get a more robust picture of the individual. So for instance, if we said, okay, well, this individual needs food, so we will just refer him to this food pantry and then that will be taking care of that. However, when we start mapping where the closest location to the pantry is and where this gentleman perhaps would live in relation to that and the distance and how many people are being served, we start seeing some more little difficulties that we hadn't perhaps thought about. So for instance, when we mentioned before, is this person eligible? Well, if they do not have a good level perhaps of literacy or they don't have access to some of these documentation, then sometimes that can cause barriers to some of these places. The other thing is we can refer people, but there is a finite amount of resources. So if we're sending somewhere where there's only 200 people allowed to be served each month and they've already served those people, then there's not going to be able to have any impact on his need for food. So we talked in the introduction about how 2020 has been quite the challenging year. And so while we're doing this work and we're connecting people with resources, all of a sudden, like everyone else, we had to adjust to the impact of COVID and try and figure out how do we keep meeting these needs of individuals? How do we understand now people might be even more vulnerable because we know that there's things that make people more likely to become more ill when they contract COVID. So my colleagues started developing something that they called the vulnerability index, and this was specifically in relation to COVID. So we've developed vulnerability indexes in relation to our other projects, particularly like I showed you some of the mapping and some of the higher need areas. So we've done those sorts of things before, but this one was very specific to us, the current climate. So what we looked at this was there was also very much, as you've seen, there's been lots of mapping being done across, the world, the US, and obviously Texas and Dallas County. So it's those maps were general to say where cases were, or where people had been contracting, but we wanted to know if those cases were going to be coming, where are the places we need to worry about? So where do we want to think about to have perhaps testing sites, or where do we need to go be doing testing for people that might be more vulnerable to this, so they're not going out and about? And then where are our vulnerable patients? So where are the areas where perhaps, regardless of if they're getting the information about stay home and stay safe and what not to do and things, they might not have perhaps choices about those things if they live in a household with, it's multi-generational, or they live in a household where there's essential workers that are having to go out and there's no choice. So trying to understand who those vulnerable people are and plan for those. So I mentioned before PCCI, we do lots of predictive modeling. So we use data to create models that drive our decision making. So we're able to aggregate lots and lots of information, pull out the important pieces, and then use that to help identify opportunities to change things, basically. So we pulled in things like the social determinants of health data into this. So we used something called the Area Deprivation Index. We looked at people's comorbidities. We know there's things like diabetes and so forth that make people, when they do contract COVID, that they tend to do less well. Things like age as well. Demographic information, we started seeing that there were certain demographics of patients that seemed to be hit more severely with COVID, and also how people are moving about. So I mentioned before the stay home, kind of stay safe stuff. So we were able to pull in a bunch of data from different resources. So we used DFW Hospital Council data. We used something that we call the Area Deprivation Index that we've adapted into something called our community-wide data set. And then also taking the diagnoses from Dallas County Health and Human Services and also Parkland Hospital. We used census data and then some mobility data. So I'm conscious of time, so I'm going to zoom through a little bit here. But this is an example of some of the things that we were able to identify and map. So we were able to look at where the comorbidities are. So the things like cancer, diabetes, hypertension, obesity, these things that we know mean that people are likely to do worse when they contract COVID. So where do these people live roughly? And this is just an example. We were able to look at our vulnerability index and see how it compared when looking at true positive rates and also COVID-like illness rates as well. We were able to try and figure out where are the zip codes that we want to be thinking about helping people perhaps access testing or access resources to stop them having to go out and about. So can we get food pantries to deliver to people in areas that we know are more vulnerable rather than having them go out if they have a food need? Is there a way to connect people with resources that they don't have to physically leave their location? We can get things to them. So combining all these things, we're able to kind of get a good overlay of where these areas are, or these people are. So basically, looking at all these things, we're able to aggregate different sources, different data, and to provide a more holistic view of the person that we're looking after. We saw a lot of time during because we continued to deliver our program where we're looking after people with Medicaid and Medicare and referring them to community-based organizations through navigation. During that, particularly when the pandemic first began, there was a vast reduction of people, as you probably saw and observed, going to the hospital, going to the emergency room because they were rightly so trying to stay home, but perhaps sometimes not rightly so because they genuinely did need to access care and stuff. So by having that kind of touch point and that connection through the navigation process, we were able to identify or help people or guide people that if they genuinely did need to go to the emergency room for, chest pain or, anything very serious, they were able to go and do that. We are also able to keep track because we have this kind of community resource index through pieces, through the technology that we have, we were able to kind of do a day-by-day, almost live update of what the resources were available. So for instance, many of the food pantries changed to drive-through versus being able for people to walk in. Well, that's a big deal if you don't have access to transportation into a car. So we were able to keep on track of those changes to services so that when we were making referrals for people for their needs, that we knew what the kind of the state of play was for those places. Some of them didn't have volunteers anymore, so they had to reduce their hours and services. So we, through being able to have that data from the community, as well as the information that we had previously, we were able to continue to address those needs, meet those needs, and carry on as we were doing. So I will pause there and ask if there are any questions that I can answer for you.
So one of the questions that was asked, and just so you know, Dr. Naeem, we still have lots of time. So if there's anything in your presentation you want to go over in a little more detail, please do. So Joan Gunther asks, what areas does PCI serve in DFW?
Sure. So PCCI serves, I say everywhere, really. So we're kind of born out of Parkland Hospital. So PCCI does stand for Parkland Center for Clinical Innovation. So we're closely affiliated with Parkland. However, we are an independent entity, nonprofit. So we can provide kind of services, and we do projects all over the DFW area. The one I mentioned previously was the accountable HC. That has specific zip codes that those people are served by. That's kind of mandated by CMS for that particular program. But we have other programs that we work with, different hospital systems all over the DFW Metroplex, and actually throughout Texas as well.
Great, thank you so much. We have another question. Elizabeth Samuelson, she's asking, how many patients and people have you been able to assist?
So we screen through the AHC program. Is that the question?
I would say through the Parkland Center of Clinical Innovation program.
So we have. So if we said overall, then that's a difficult question to answer. Because obviously we do multiple different types of projects for the county, for Parkland Hospital, and some of the other hospital systems. If we think about the program I spoke to about the screening and navigating to community services, that is around 4,000 a year or so.
Okay, great. Next question is from Adnan Zaid. We have preventative programs to reduce disease burden.
Sorry, is that a question?
Yes. Do we have preventative programs to reduce disease burden?
So do they exist? Is that the question? So, I mean, yes, there are programs to reduce disease burden. I think we don't particularly run any of those programs because we're not providers as such. But yes, there's programs to exist, particularly focusing on, say, nutritional needs. We have done piloted programs before for people with hypertension and diabetes who are utilizing food pantries. So what was able to be done there was to, they worked with a dietitian or nutritionist to identify which foods that are available at the pantry would be most suitable for the people's dietary needs. And through that, they were able to improve diabetic control and also reduce blood pressure as well with that. So there is a strong argument for coordinating alignment between community services, particularly some of the larger community-based organizations that might have multiple services going on in kind of a one-stop location. The other thing that we found really interesting when we did that pilot program with the food pantry and diabetes and hypertension was that it's very much, and probably the people that are, on this call today know this well, but the establishment of building a successful rapport with an individual goes a very long way in terms of getting them engaged and participant in kind of healthy behaviors. So one of the things that was very interesting was that because people were tending to use the same food pantry multiple times per week, they were encountering the same volunteers and staff there. They were actually, because of the relationship they developed with them, they felt more comfortable sharing more with them. They were more likely to listen and kind of take guidance and advice from them because it wasn't coming from a clinical person, and it was less intimidating. So they felt more comfortable taking advice from people that they felt more aligned with, rather than listening to somebody in a clinic tell them what to do. So that was kind of an interesting, but made sense sort of outcome or finding from that.
Great, thank you for that. Next question, does PCCI have any programs in Collin County?
So in Collin County, we evaluate some programs. However, in terms of the pieces, IRIS, or the technology, if that is the question, there are some locations in Collin County that do use that technology. It sometimes becomes a little bit confusing when we talk about the pieces technology, because originally PCCI was one entity, and then 4 years ago they split into so we're the nonprofit PCCI, and then they split into a for-profit called Pieces. And so Pieces is the one that run the technology side, but because we're very closely aligned, we work together very closely. But no, I mean, we would be happy to, talk about expanding or guide or advise any other programs in any counties that people are interested in. We've been doing some work in kind of East Texas recently, like with kind of Longview area and things like that, and we've got some other things throughout the state.
Awesome, thank you. Next question is from Sherilyn Johnson. Can non-Medicare providers be listed in the IRIS system as community services?
Yes. So so there's a couple things within the IRIS system. So there's IRIS kind of users and people that are on the IRIS system and have got the package and the software and are able to utilize all the resources. There's also the ability, though, to add community resources onto the IRIS system where they can be listed as somewhere that people can be referred to. However, then that loop is not closed. So for this system to work as it should in an ideal situation, where if one community organization was referring to another community organization, both would be full IRIS users, which involves like purchasing the software and so on and so forth. However, if one is an IRIS user and one is not, the IRIS user is still able to refer to the non-IRIS user, but then that data, that closed loop is broken basically. So you can't see that referral has been definitely completed, and you can't see what's happened to that person at that referral. So that's one of the challenges. And when we think about kind of having a shared data system, I think that's why things like this are difficult to do, because you have to get everybody on board and, in agreement and using the system. So, yeah.
Another question about the IRIS system. Is the IRIS entry system Dallas-based, or is it used in other communities? Can it be connected to our Health Info Exchange database here in Houston?
So it is used in lots of different communities. It's not only based in Dallas. It can also be, they have the API now in App Orchard, so they can integrate it into Epic as well. So it can be integrated into electronic medical records also. Awesome.
Next question from June Stark. Do you know how a Medicare or Medicaid patient becomes eligible for the Accountable Health Communities program?
Sure. So they have to live in a certain geographical area, and then they also have to have had 2 ED visits in the last 12 months.
Thank you. Next question's from Martha Montgomery. She'd like to know, how is the program funded?
The Accountable Health Communities Program is funded by CMS.
Okay, thank you. From Teresa Ann Lalou, what percentage of client data is complete, meaning every expected touch point has contributed to the profile?
So I think there's 2 ways in hop in, and if or just I can clarify it further. So I think when you mean the data is complete in terms of all the information that we want to know about the person, so demographic information and things like that, and then also that they've gone where they need to go to get their need met, that's been documented there, and then closed and back to us again. I think that's how I'm understanding it, for it to mean complete. That's a difficult question because I'm not trying to hedge out of it, but it's difficult because it's very variable. There's certain community sites where the data is really robust and really complete. There's other ones where I think I mentioned before, if you have volunteers or they're not on the system, or we've referred somebody to a location that's not on IRIS, then we don't have a full insight to that. When both systems are on IRIS and we have a good amount of kind of closed loop and it's gone as it should do, I would say probably I'm going to say 65 to 70.
Okay, thank you so much. Are there any other questions that you all would like Dr. Naeem to answer before we say goodbye? Susan, do you see any questions that I do not see? Actually, I do have another question here.
Mm-hmm.
Is there evidence that preventative therapy services, particularly occupational therapy-based interventions, can reduce falls, hospital admissions, and healthcare costs?
Oh.
There is Are you still there?
Oh, hi. Sorry, I was just saying that I can see, but the sound went off.
Oh, okay. So did you hear the last question about the evidenced preventative therapy?
I'm sorry. Are you able to repeat it? I don't think I did.
So there's evidence that preventative therapy services, particularly occupational therapy-based interventions, can reduce falls, hospital admissions, and healthcare costs. There is, however, very limited access to preventative therapy services. Have you done any research looking at community-based models of preventative occupational therapy or therapy in general?
I myself have not done any research into that, and PCCI as a group has not done any that I'm aware of, but I think it's a really great point, because I think there is probably good evidence for it, but it's not something that we've looked into ourselves. But if anybody has seen any, I'd love to, if you could share. I think it's a really important point.
Awesome, thank you. Another question we have from Mary Callahan. Do you know of Care 360?
Do I know of Care 360? No. I'd like to hear about it though.
Okay, great. Thank you so much. Well, thank you, Dr. Naeem. We really appreciate your role in this presentation today. Thank you so very much. And we wish you a wonderful day.
That's great. Thank you so much. I'm excited to hear the other presentations and hear from others.
Thank you.